So my presentation, as Dr. Minochin noted, I am a social worker by trade. So this presentation is really focused on the role of social workers. And I designed this with practical application in mind. So some of these things you might be putting into practice in the clinical setting. If you are a hospital-based social worker, you may find yourself in these slides. If you are another type of clinician, please raise your hand in the chat and pipe in at any moment in time. I wanted to start off by kind of putting into context where people think social workers fit in the dementia picture. Typically, we as social workers are seen at the very beginning of a diagnostic process, like right after a person either comes into a clinic or right after the diagnosis may be made in a clinical setting, where we meet with families, typically caregivers with their loved ones by their side, and we talk about what the diagnosis of dementia might mean. And that's what people on the outside assume social workers do in this context, that we talk about the stages of dementia in more depth. We might have a little bit more time than clinicians have had. We talk about the increasing care needs the family may or the individual may see over time. We allude to needing to get your affairs in order, which is often code name for financials or maybe advanced directives. And we hint at the inevitability of long-term care, needing to find ways to identify home care, maybe assisted living if you can afford it, or if you're in the Medicaid program in states that allow for that, or even the nursing home. But as social workers and others, we fail to recognize the reality in the lives of all people who are older, that as Dr. Chalmers talked about, they often live with complex medical conditions outside of their dementia. And that hospitalization happens. It happens all the time for older adults, and it is more complex for older adults with dementia. Accidents happen, like falls. Dr. Chalmers talked about falls risk and ways that we can mitigate falls risk, and I'll point to that in my presentation as well. People with diabetes have challenges controlling their blood sugars, right? They have challenges managing their medications, especially those who live alone. Again, as Dr. Chalmers pointed out in her case study, people live alone and they're trying to manage complicating factors outside of dementia. Heart attacks and arrhythmia and COVID, I mean, oh my, people go to the hospital. Hospitalization happens. So social workers assist people with dementia in dealing with challenges like these medical conditions that I mentioned, as well as barriers to care both within the acute setting and once they are discharged from the acute setting. So my learning objectives as part of your continuing education units, we have great learning objectives. Hopefully, by the end of our presentation today, you'll be able to describe 3 actions that caregivers can take to reduce the risk of unplanned hospitalizations. That's where the focus of my presentation will be today, although we'll talk very slightly about planned hospitalizations. For those of you on the line who are our pharmacists, we're going to talk about common medications that may put older adults at risk for hospitalization due to adverse drug events. I love that there are lots of clinicians on the line, so I don't have to bring out my thesaurus as I do with families. Adverse drug events that may be due to accidental overdose of these common medications. I want us to focus a little bit on coaching caregivers on language that they can use to accurately describe dementia when they meet with a hospital team during hospitalization. And then at the end, we're going to examine one social work-based model of hospital to home care transitions for persons with dementia that has a very impressive less than 1% readmission rate post-discharge. And again, it's a social work-based model. As Dr. Minochin mentioned in the beginning, I do provide consultation to home and community-based organizations, and this is one of the organizations that I'll talk about today. I also needed to make note, I have no disclosures other than this one, that most of the content at the early part of this presentation is part of a trademarked under license agreement with Cognitive Solutions, which is a for-profit organization. It's a Thoughtful Hospitalization is a workshop for caregivers that we train them as social workers and case managers on how to plan for hospitalizations. So if you are interested in that, you can find me afterwards. So I wanted to also point out that I am living the dream. This is my grandmother. She is 96 years young, and this is us 1 year ago to this week during a 7-day unplanned hospitalization for what she thought was a upper digestive problem, which ended up being a tube for gallstones. So this is us in the hospital, and we survived 7 days. I was the night shift, so social worker by day, primary caregiver by night. And after 7 days in the hospital, she returned home, and a slightly different looking young lady. OT's on the line. Notice macular degeneration, folks, the light's there right behind her seeing eye for the day. She did return home safely to us and remains with us today. So I have lived this dream, and I share kind of the battle scars that come with it, not just from the social work perspective, but also from a personal perspective. So as we learned from the previous presentation, persons with Alzheimer's disease and related disorders or dementia have other health issues. 90% have one or more chronic conditions, and they're pretty expensive from the healthcare perspective. From the funding perspective, Medicare beneficiaries who have dementia with a comorbid condition costs 60 to 300% more per beneficiary per year. So social workers in this role are really assisting people with dementia in dealing with these challenges listed in bullet point number 1 here, like medical conditions and other barriers to care. I know many of you are versed in what is dementia. We're not going to go through the umbrella of different types of dementia, but I did want to highlight ways in which problems with impaired thinking of persons with dementia are barriers to their care, especially during hospitalization, and challenges that their caregivers are dealing with outside of the medical care that's happening. So we know that people have problems with memory, with language, not just English as not a primary language, but having trouble both speaking and understanding the spoken word or the written word, abstraction, organizing their day. That 96-year-old young lady loves to drink coffee, but she couldn't perk one to save her life. Reasoning, making decisions, perception, the way that they're seeing the world and the lights and the sounds and the smells in the hospital situation. Their ability to maintain attention if they're being asked a question is often compromised. And these are skills that decrease over time. So we're not talking typically in this presentation about people with the earliest stages of dementia. We're talking really mid to late stage dementia. They have problems with judgment. So there's some essential information that we as caregivers can pass on to we as social workers can pass on to caregivers and persons with dementia that have the basic building blocks for how to avoid or how to survive a hospitalization experience in the acute care setting. I'm going to talk about a caregiver's best tool, the number 1 thing that we can equip them with to go into the hospital setting with. I'll touch very lightly on advanced care planning. That is a whole other set of continuing education units that you should approach as well. And then I'll talk about some at-home basics that we can coach them to put into place now to either avoid hospitalization or, again, to survive the hospitalization experience. So this number 1 tool for any social worker out there, any caregiver, every caregiver needs a notebook. Now, there are complicated ways of creating and utilizing things like the electronic health records and online tools, but I really count on making sure that a caregiver has a notebook at hand inside of their purse, in their car, ready to go during a hospitalization experience, because that's really going to help them to write down rather than just count on their hearing and memory themselves of what is happening, what caused this acute care situation, what's happening in the hospital, what are the nurses, the doctors, and others talking to them about, what changes in medication. All of these have to be written down so that the caregiver can keep track of what is happening. So the biggest tool has nothing to do with something that costs a lot of money, but we really want to impress that this is the most basic building block, is having a way to document what is happening with my loved one, what changes are being made, where is my loved one moving to next, what room number are they in, what are the hours of visitation, how many people can be in here at this time. These are the types of things that are said in rapid succession to caregivers during a hospital experience that they really need to have some active way to keep it together when their mind is racing and they're really trying to make sure that their loved one survives. They themselves have to survive, and this notebook is the key way for that to happen. So the next thing that I wanted to, is in very slowly but very cautiously step into, is that we need to talk to them to make sure that they have their advanced care directives. Anytime we talk with caregivers in a clinical situation, or if you're a care manager outside of the clinical situation, if you're in private practice, every time that you meet with your client, either the caregiver of a person with dementia, you want to be talking about, are their advanced care directives up to date? Who needs to know where or what is said in the advanced care directive? I would say that everybody who is part of that person's circle of care needs to know. Everybody in their village needs to know that there are advanced care directives and what they say. What types of advanced care directives that you help people to access is really up to your professional judgment. The MOLST and the POLST, the portable medical orders for life-sustaining treatment, and the specific ones to your state may be what most of you fall back on. But caregivers don't have a lot of time. Some of them may have gone for a durable power of attorney for healthcare. The individual may have a living will, and most often caregivers do not know the difference between these different types of advanced care directives. So for example, when we were in a recent hospitalization, we had to make a decision about so we have a do not resuscitate, but we did not have a do not intubate, which in our family situation, the primary caregiver is my mother as well, and she had not had that conversation about whether resuscitate, and she assumed resuscitate and intubate were the same thing. It was not in the advanced care directives. So just understanding the different types, again, this is something that you can get some additional education on or become an expert in, and hopefully there are some experts on the line who during question and answer will pipe up as well. So lots of people need to know that these exist. When do we update? The hint is now, later, tomorrow, yesterday, all the time, because people's wishes change, situations change, health status changes. Updating, this is really not a one and done. Advanced care directives should be something that we continuously talk to about our clients. Where should the advanced care directives be? I mean, in a dreamy world, if you are part of a closed system, it's in your electronic health record for your client or your patient. In the real world, it's a piece of paper that a caregiver carries around with them that may have tears on it and swiped letters across it because it's been touched so many times. So it should be on the person. We encourage our caregivers to keep many copies of the advanced care directives in accessible places. And they need to understand why. Why does there have to be an advanced care directive? I worked with a client who both she and her person with dementia were in a car accident, and both of them were impaired to the point where they needed an additional proxy for healthcare to help make decisions for both the caregiver and the person with dementia. And in those situations, the caregiver would not have those advanced care directives on their person. So why do we need to spread the word about these advanced care directives? Because emergencies like that are reality and happen every day. So planning for these emergencies, what can we do now in the home, or what can we prep our caregivers and family members for today to prepare for either a planned or an unplanned emergency situation? Make sure that either in that notebook or folded up inside of a wallet or a purse is an up-to-date medications list. We can't count on the electronic medical record system as Dr. Chalmers talked about. When you look in the medical record itself, there's lots of listings. The pharmacist may be refilling things that aren't necessary anymore. What are you giving to your loved one on a daily basis, and why should be part of that medications list? Again, the advanced directives have to be in a place that's accessible. Have a listing, again, in that notebook or elsewhere about the multiple diagnoses that we're talking about, the 5 or 6 high level challenges that they face medically on a daily basis, not just that they have dementia, but that they're also a person with heart disease or diabetes or other chronic conditions. Make sure that there is a listing of assistive devices which that person uses on a daily basis. I can't tell you how many times, as Dr. Chalmers talked about earlier, that you don't have teeth, but you need the dentures as an assistive device in order to survive that hospitalization, because it's not going to be on your record that you need pureed food. You're going to have regular food and you may not be able to eat it. So assistive devices that include your eyeglasses, your hearing aids, and any kind of mobility device, those should be easily accessible, or at least a list available for what you might need. For your loved one in that emergency situation, especially if they have hearing aids, making sure that there are additional batteries available quickly and backup glasses if that's something that somebody has access to. They get lost in the shuffle, especially between the emergency department and an actual floor where they may be moved for more continuous stay, a more continuous hospital stay. So say you have, we're preparing for an emergency situation, caregivers need to know what emergency medical services professionals will look for when looking for medical information. So 911 has been called, the emergency medical services is on its way, you might have had a car accident, you might be out in public. The first thing that they're going to look for is medical information about the person on the person. So this little hand icon means that they're looking for a medical ID bracelet or necklace that says something about their chronic conditions. And we highly encourage people to make sure that they have that emergency identification information on their person that also identifies that they have a cognitive impairment. So not just that they have a pacemaker or other challenging complications, that the medical information on the person includes their dementia. We want to make sure that that emergency information is in a wallet. Hopefully, if it's an at-home situation, that the typical place that emergency medical services look for is on the refrigerator. And we can also coach people to start to put medical emergency information in their cell phones. So in a wallet, this is just simple, making sure that inside of their wallet, they have a little emergency card that has information about who the caregiver is, that they, not just for the person themselves and their identifying information, but the caregiver's information and basic information about their dementia stuffed into their wallet or in the caregiver's wallet. On the refrigerator, this is a system, this particular thing that you're seeing here is the file of life. Some districts call them the vial of life. These are often services that are provided at the county level by emergency medical systems that allow for free or low cost kits that we can provide to our caregivers that allow them to put basic medical information, the diagnoses, the medications, the contact information for others, their religious preferences, their language preferences, and emergency medical professionals who are working in an ambulance situation are trained to look to the refrigerator to see if this file of life, vial of life, or other medical information is available to quick grab and go in that emergency situation. So if you don't have this, this is not part of something that you coach your caregivers to use. I mentioned the file of life, which is a county-specific activity in Montgomery County, Maryland, which is where I live. But the vial of life is online, has just a one-pager. It's not complex. It's not a medical file that you're putting on someone's refrigerator. Inside that little Ziploc bag that you see on this refrigerator is just a one-pager that has the person's name, their age, the contact information for their primary caregiver, and the information about their diagnoses. I love technology. One of the ways that caregivers can utilize technology nowadays is to download a free app for putting in case of emergency contacts on their cell phone, kind of like the way that you can use your cell phone at almost any time to call 911. An emergency medical staff person can look on a person with dementia's telephone, if they have one, or a caregiver's telephone, and when it's turned on without access to all of your contacts, they can flip it open, and in case of emergency contacts comes up right up next to dial 911 in case of an emergency. So this is a high-tech but pretty simple way for someone to be able to identify the emergency contact of a person, perhaps with dementia, who's out driving, who gets into a car accident and is confused, because in most states, driving is not revoked with your dementia diagnosis. The cell phone is a great way to at least have that primary caregiver be able to access in an emergency situation. So I have a couple of kids, and it's been in vogue for a number of decades now that when you go into a hospital setting to give birth, that you bring a birth bag, right? Like as you've got your favorite lavender scent and your a cozy wrap to put around you and your own pillow and a change of clothing. We suggest that you coach your caregivers to create a caregiver self-care bag to take in case of emergencies and to have ready at any time, ready to go into the hospital situation. This really provides them comfort and care in a really chaotic situation. And so I want to know if you were, let's get some chatting going. If you were to create your own self-care bag, say you're a primary caregiver, what's going to go into a self-care bug out bag that you're going to take in case of an emergency? What's going to be set up by the front door next to your purse if you'd have to leave for an emergency? I like the notebook, your debit card, phone charger. Oh, I like wipes. Your protein powder, yes. A way to keep alive, sustenance for yourself, because those potatoes are not the tastiest thing on the planet. Cold mashed potatoes in a hospital. Excellent. And we're going to keep these. I'm going to add them to my list. Keep going, keep going. Snacks, something to entertain yourself. A word find book keeps it nice and quiet. It's nothing that the person with dementia is going to be necessarily interacting with unless you want to talk to them about, what questions can they help you to answer. Your essential items, your contacts, extra wash. Keep yourself fresh. You might be there. As I said, I did a 7-day stint in the middle of the night. Yeah, you can definitely smell yourself. Marianne, I like yours. Patience. That's right. Forgiveness for yourself in times of crisis, also good. Yes, your power of attorney, get those advanced directives with you as well. They go in the purse. Great. Wonderful. Okay, you guys are all prepared. Let's see. Survey says the caregiver's medication. So I saw someone say their own protein powder. That might be part of your medication regime. Make sure that you have several days, if possible, of your own medication, or you grab those on the way out. You may not be coming home for a time, and the hospital is not going to refill yours. You may not have a chance to get out to get those in this time of crisis. So a couple of days worth of the caregiver's medication, always good to have. I saw a couple people say phone chargers, for sure. Phone chargers, phone numbers. Again, that notebook, should you not have access to technology or your phone dies, you don't remember that charger, using that notebook to write down some key people's telephone numbers. Who's going to take care of the cat? Who's going to pick up the kid from school? Having those phone numbers is really essential, and we're so dependent on our phones. What if you forgot it on the way out the door? Snacks for sure. I mean, really the only thing that I have found that's left at midnight in the snack machine at a hospital are pretzels. And I'm already a pretzel sitting in that chair trying to get comfortable. All I have left in that snack machine are pretzels to eat myself. Some business cards. So this is one thing we coach caregivers to try. It's not to share thoughtful hospitalization with the staff or ways to get trained in the 5 M's with the staff, but it's a business card. That's my business card. I, Kate Gordon, am the primary caregiver for Ms. Jacobson. This is my telephone number in case of emergency if you don't find me in this room. Here's the secondary primary caregiver who's coming in after me. And here's some basic information about my loved one. So business cards to hand out to the staff themselves or to leave close to your loved one. So business cards, something new to think about. They can even use a 3x5 note card or tear out a page from their notebook. Back to that pretzel machine, $5 in small bills or change for the vending machines. In some communities, we're not using the credit card for vending machines yet. So anticipate that you might need some small change for your vending machines. I saw someone say a change of clothes. Saw somebody else say a pillow, for sure for both of those things. At least a clean shirt. If I can't change my whole outfit, have a clean shirt. Often it is chillier, not because the hospital itself is chilly, but because you're under a stressful situation, and many people get cold in a stressful situation. So having a blanket and maybe a long sleeve clean shirt is the way to go. I don't know about the rest of you, but I live and need my cheaters, my readers. Having an extra pair of those inside of that self-care bag is also really helpful because there's a lot of paperwork to read. There's a lot of small print. Making sure that you've got an extra pair of reading glasses or cheaters is really essential. And just as you guys listed some really wonderful things that you personally would need, coach your caregivers to personalize this bag. And again, have it ready to go, just like your niece who's expecting in 2 weeks has this great bag with the essential oils. Make sure that your caregiver thinks about this way in advance because hospitalization happens. So let's talk a little bit about other ways that we can coach caregivers to prevent avoidable hospitalizations. And just for fast facts, people with dementia are super complicated people. Talked about it earlier. The numbers of complicating conditions that they have, they account for 6 million hospitalizations in the United States right now. Persons with dementia account for 6 million hospitalizations a year. And of those, 40% return to the hospital from home in less than 30 days after discharge. 6 million people, 40% of those come back for the same problem that they came to the hospital with in the first place. So we'd like to be part of breaking that cycle and working with caregivers to avoid some of these preventable hospitalizations. So why are people with dementia ending up in hospitals? Here are some of the leading causes. This comes from the Alzheimer's Association's facts and figures. That should say 2023, not 2013. But here are some reasons that they come to the hospital. Falls and trauma. Dr. Chalmers talked about that before, about falls. It's a big challenge that people with perception challenges and dementia have. They're complicating conditions, 17% from heart disease, combined other reasons like I waited till the last moment and now there's a cascade of junk happening at the same time and I'm coming in, I fell, but really it's because my blood pressure had changed. And by the way, I may have pneumonia at the same time. So combined other reasons is the highest number that you're coming in with complex medical conditions that have compounded on top of each other. We also see dehydration and malnutrition, not eating that protein powder, and delirium and mental status change, which we'll talk a little bit about. So these are some of the leading reasons why people are coming to the hospital in the first place. But what can we do to coach caregivers, especially as social workers and our partners in allied health work to do to try to avoid some of these? So in the home, preventing falls, two of the biggest categories that we can help people to talk through and work through, even if we don't see inside of their homes. If you're not a geriatric care manager who's going into a home, you may not see what's happening, but we can certainly talk to caregivers about what their living situation is like. The picture here for lighting is one of the biggest concerns, especially if you're cohabitating. And for example, the person you live with suffers from chronic migraines. The lights have to be off for them, but what a harrowing condition for a person who is living with dementia who has problems with perception. So lighting leads to falls and poor lighting leads to falls. Other things like obstacles around the home. This is a picture of a typical middle-class home with very low furniture, with different types of rugs on the floor. That black cowhide rug to a person in the middle to late stages of dementia could look like a giant hole that you have to step over, and you're going to go topple over onto the couch in order to avoid the giant hole. And how about the dings and dents that you can get in your body from trying to navigate those small areas, especially if you're working with a mobility device? So I'm sure that the occupational therapists on the line are saying like, of course, this is so basic, but we as social workers, unless we've been trained in this area or work on falls management, others might think like we teach this in falls prevention class. Well, not every person with dementia goes to falls prevention classes, nor do they go conjointly with their caregiver. So talking and thinking about these are just extra checkpoints that we can have in our arsenal of trying to help people to prevent hospitalizations. And even if they do all those things, they have an occupational therapist who came for a home assessment, and they may have gone to falls prevention. We as social workers need to continue to have this on our list because this is one of the highest reasons that people go into the hospital. So reinforcing and asking if the home is safe and free from falls hazards is something that we can do as part of a multidisciplinary team to really assist our families. So I mentioned really lightly, what are some referral resources that we can aim families at? Hopefully, if they're eligible for an occupational therapy Medicare paid evaluation in the home, that's great. You don't have to have hospitalization in order to trigger one of those evaluations. It does have to be prescribed, but look into that. If you've never referred a client to a home evaluation, it's something that many people are eligible for. There are home modification programs where free or low cost grab bars, no slip tiles, ramps, improved lighting can be installed in people's homes. Oftentimes, and especially urban areas, those are things that might be supported by public programs. And I work with a lot of area agencies on aging. I would be remiss if I didn't say they are a great source for falls prevention programs. And all of us who've paid taxes in the past 1 year, thank you very much. Some of those taxes go towards supporting the falls prevention programs at the local level. So I see a little bit going on in the chat about making sure that we understand the proper installation of grab bars. Thank you very much. It's not a handyman, my dad doing it himself kind of job. The height of those grab bars may make a difference depending on the height of the individual. So if it's put at a 36 height, that lovely 96-year-old lady is 6 foot tall. She needs her grab bars at 36 inches. At 32 inches, she would fall over. So really understanding what that means for an individual and having the right kind of professionals work on it. Great point. So another thing to think about in terms of prevention of hospitalization is to look at that list again of where are these people coming from. They're coming from trauma situations where they have been injured, not necessarily just from falls, but other injuries. And driving accidents is one of the #1 causes of trauma for persons with dementia. And I know what you might be thinking. People with dementia shouldn't be driving. That's actually not the cause of trauma and driving accidents. The cause of trauma for people with dementia and driving accidents is that they're not wearing their seat belts. Their caregiver forgot to tell them to wear their seatbelt. They fought their caregiver and don't want to put on the seatbelt, but it's actually trauma to the upper body due to non-use of seatbelts. A little surprising, a little shocking, but driving accidents and the injuries to persons with dementia and the trauma caused is typically by not wearing the safety belt, either in the front or the rear of the car. Transfer near misses. So, you're trying to help someone, you don't have a Hoyer lift at home, helping them to lift up. It's just you, the caregiver, lifting your 250-pound father from the bed, or the spouse from the bed to the chair or to the wheelchair. And they made it into the chair, but they also cracked a rib as they toppled slightly over on the side. So transfer and the challenges of getting up, down, left, right, forwards, and back in those transfer situations and the near misses that happen also cause this trauma. So these are two of the top reasons and the types of trauma. Talk a little bit about another cause of hospitalization, are problems with maintaining proper nutrition and hydration. So if you are a person caring with a loved one with dementia and you are lucky enough post-COVID to still have access to adult day programs or adult day health programs, during the daytime, that's a great way for people to maintain proper nutrition and hydration, because they get constantly cued, typically on an hourly basis, for nutrition and hydration. They're drinking their water and they are eating proper meals and properly eating them with all of the proper implements. Nutrition counseling and meal planning is often something that, especially we as social workers, it's not really in our purview. We don't really know about it, but some Medicaid eligible clients, as well as Medicare Advantage program clients, those programs may pay for additional support, either for this adult day program or for the nutrition counseling. So making sure that not just that they have access to Meals on Wheels, but how are they maintaining proper nutrition and hydration in the home in the times where those meals aren't part of their everyday life. And we have other people in the allied professions who are helping out, but we have to reinforce what they tell our clients. So I have a wonderful story about a friend of mine named Henry. Henry was living at home with his wife, and she was having a heck of a time managing his diabetes. And by chance, they had a visit from a home health nurse who came in to do a full home assessment, but really she was there to talk about the challenges they were having with managing Henry's diabetes. And they went throughout the home and found a couple of things that were problematic. So for example, in the sink, there was a bowl with clear vestiges of ice cream and the smear of a little bit of chocolate sauce. And it was pretty early in the morning that the home health nurse had come in to take a look at the situation and asked Henry's wife, what's up with did you have ice cream for breakfast? And she said, no, he gets up in the night and he makes himself a little something. And the little something is the ice cream from the fridge. He'd always had a bowl of ice cream at night. And so the home health nurse mentioned, well, if he can't see it, he won't get to it. So how about we put that ice cream for a special time into a bag and we put it back in the freezer. If Henry can't see the ice cream itself, he may not go for it. So if it's hidden from sight, he might think you're just out of it because he's not likely to open up that bag because that's a step he's not used to, and the ice cream disappears. Maybe that will help to manage things. She looked around the house, around the kitchen, especially for some of these other temptations, and gleaming in the corner was this beautiful banana tree filled with the most tempting and delicious bananas with no marks on them, just bright yellow. And the home health nurse asked his wife, what's up, what's up with the bananas? And she said, well, they're healthy. He can have as many as they want because it's healthy eating. One of those bananas is like a couple of spoonsful of sugar. It doesn't help the medicine go down right. So sometimes it's as simple as helping our clients to understand it's just hide the bananas, hide the ice cream. It's something as simple as a change to the environment. It doesn't take a home health nurse or an occupational therapist. It's just talking through some of the main causes of concern that our clients might have in their own homes. So hide the bananas. Okay, so for those of you who are our pharmacists at the table, I've got a question for you. So preventing hospitalization, there are 4 medications that lead to 67% of medication-related emergency hospitalizations for older people. So I'd hope that you're first to the chat today. What do you think those 4 medications were or are? Or for those of you who are just chronic overachievers, what might the 4 types of medications be that lead to emergency hospitalizations? So use and overuse. Warfarin and blood thinner. Yeah, getting there. We've got a couple classes of medications in here. All right, I think we've hit max. I think you guys answered them all. So let's take a look. So the types of medications that we're talking about here include warfarin. So we're talking about blood thinners, medications that people are using to manage their heart disease or for use in stroke prevention. So warfarin and oral antiplatelets or oral anticoagulants such as Eliquis. These are things that we see in almost every older adult's arsenal who are dealing with heart disease and stroke prevention. Diabetes, I've mentioned that several times today. Insulins and use of insulins and oral hypoglycemics are often challenging for people with dementia and their caregivers to understand. But why are these 4 kind of categories of medications causing problems? It's because people with dementia and their caregivers have a hard time managing medications. They are taking too much, they're taking too little, they're skipping their doses. Sometimes they're making the trade-off between paying rent and medication. We know that this is true, but most often it's because people with dementia are doubling. They're taking it. When their caregiver comes for the day, they cannot remember whether or not they opened up the pill box, and they take a second dosage of a warfarin. These are really dangerous situations, and we find many people, as I said, 67% are from these 4 areas. Doubling, because that's 67% of all hospitalizations, just those that are medication related. So it's a huge problem that we're facing. So hospitalization happens, as I've said, it happens for these unplanned situations with falls and over medication, but they also happen as part of planned admissions. So if it's an unplanned admission, you've got some high points. Grab the notebook, number 1. Get your advance directives. Make sure that you have the assistive devices that your loved one or you need to manage the hospitalization, and take that self-care bag along with you. We have a little bit more time to coach caregivers if it is a planned hospitalization. So it gives caregivers a little bit more time, and we can coach them through having some advance notice to be able to work with pre-admission screening with an intake professional where they can talk about what medical and non-medical care might look like on the floor if it's someone who's going to be there for a stay itself. Caregivers, and maybe even you on the line, don't know who the team members are in the hospital. We don't speak hospitalese. We don't know what the difference between a social worker and a hospitalist is. Who are the people in your neighborhood? We have to talk to them way in advance, coach them way in advance about who they might see in a hospital situation. So if it's an unplanned or even a planned situation, they might talk to an intake or an admissions person, and what's their role? What information do they need to have? My next door neighbor is a hospitalist. I just thought he was a doctor, right? Like that's what the typical person says. What's the difference between a hospitalist and the emergency department staff? Who are the nurses and what are their roles? That people don't know that you might encounter an occupational or physical therapist in the hospital setting itself. They think that that is for post-acute care or something that you do at home or you go someplace for. They don't see us, the social workers. There are many of you on the line who work in acute care settings. People don't know that we exist and we're there to help as well. And that sometimes we're discharge planners, but sometimes nurses are discharge planners. And what's the role of me as the social worker versus the discharge planner? How do we work together? These are things that the average person does not know, they're not equipped for, even though they may have been in a hospitalization situation with themselves or their children when they were younger. And there are these funky people called care coordinators that might be part of a health plan who are trying to help the caregiver by reducing the use of healthcare, unnecessary healthcare within that hospital setting. So for you to know, for us to remember, caregivers don't know who the people in the neighborhood are in the hospital setting. And that's confusing. It needs to be in the notebook. We need to ask them to write down every time that there is a shift change. And Dr. Lane is also going to cover after me some about the dementia-friendly acute care more in depth and in his next presentation. So I just want to mention that people don't know who they're going to encounter in the hospital situation and why they need to know them. Another big part of coaching is coaching people to ride out the storm. It's not just that you have to have that self-care bag, but how do you as the caregiver survive yourself and help the person with dementia surviving? So one of the number one things that we need to work on and have in our notebook as well is an elevator speech, introducing my person with dementia to every staff member that I come in contact with. If they introduce themselves to me as the caregiver or to my loved one as the patient, I'm going to introduce using an elevator speech with that staff person. And it's a patient-centered elevator speech. It's about them, not about necessarily the condition that they're in there for wholly. But for example, my grandmother has vascular dementia. And that means, it means something different for every person with vascular dementia. It means that she will say, I can't hear you. But it's not because her hearing aids are not in. It's because her dementia has her lost. She's lost the ability to understand words that are spoken to her. So talking louder won't help. Getting closer won't help. Her dementia has affected her ability to understand words. And have this elevator speech in your notebook. What's the most important thing to know? Don't yell at my grandma. She's not going to understand you any better. You need to understand, or the caregiver needs to understand, that there's a challenge in flow of information sometimes. Even in the best electronic health record system, there's a challenge between what has happened in the emergency department and what's going to happen on the floor. Medication that was given, things that were said, all of these nuances that you think are the caregiver thinks is directly being passed on, often not. So back to their notebook, making sure that they're using the notebook to inform the team and listen to what the team at each level is saying, because you know what time the last time the medication happened and things like that just are sometimes inaccurate, and the caregiver has to be on alert for that. Caregivers need to know that they have rights with meal ordering and the types of meals that their loved ones get. They are eligible most times to ask for a special diet if it wasn't part of the regime that was talked about in the emergency department, to talk about what their specific diet is like. And sometimes, underscore sometimes, you can bring in your own food. It doesn't always have to be the hospital food. You have to get some permissions, but you know, a chocolate shake every once in a while, if it's going to keep the peace, it's okay. And the other thing to note is, if you look at this picture, this is a typical meal being delivered in a hospital situation. So the aide is coming in with this meal, and the meal is under a mushroom. If a person with dementia encounters this visual in front of them, are they going to know to take the top of the mushroom off and find the meal? Not if they're visually impaired or their judgment and reasoning is impaired. They don't know how to peel off the plastic from that glass of water to get the hydration that they need. So meals under a mushroom are a problem, and it can be something that you work as a team with the hospital system. Identifying pain is a big challenge, and I know at least one other speaker is going to talk about pain management later on today. It's something that the hospital should be asking all the time. New pain, old pain, managing that pain on top of the problem that they may have come into the hospital for is a big deal. They will ask you, tell the caregiver, they're going to ask you a lot about, they'll ask the patient a lot about their pain and how to identify it, if it's new pain especially. Many, some, none, sitter resources are almost wholly unavailable outside of urban areas. That is where the hospital itself has resources that you can either utilize for free of charge, or most of the time have to pay for to have somebody who is like a home care worker temporarily sit in the room with your loved one to assist them if they are confused. It's very rare that a sitter resource is available if it's not the caregiver themselves. If that's your hospital, thumbs up. It's a great age-friendly part, but they're typically not available. So new and changed medications are also something that we're going to see frequently within the hospital situation. Again, they need to utilize their notebooks. They need to be on the lookout for things like adding antipsychotics, which happens in the hospital system, even though we don't necessarily think it's great practice. And we're going to hear a little bit more about that during our next speech. So being on the lookout for antipsychotics, and what does that mean? What do those drugs' names look like? And lastly, delirium prevention and management. Caregivers don't know what delirium is or that delirium could happen. They just think the dementia is getting worse. They think that the hospitalization or the illness or the injury that they came in with made their dementia worse, and they don't actually know what delirium is. That in short, it's a sudden onset of big change, that their loved one may be having many more problems with grasping the environment. They can't pay attention. Lots of caregivers say that they're out of their mind. Like, it's very different for them. It might not be outward, it might be inward. They can be really become suddenly quiet when they're not usually quiet, or really active when more calm. Intensive care units do a really great job of paying attention to managing delirium and identifying delirium, but other places, especially the emergency department, don't have the resources for that and may not be a big focus for them. But with prevention or treatment, this could be a short-term problem, and their loved one may not seem like their dementia has gotten worse because of their hospital situations. But the rate of cognitive decline as a result of delirium is 3 times faster in people with Alzheimer's related dementia who had an episode of delirium. So it's something that we need to help caregivers to understand. And why does it happen in the hospital? Well, everything's new. It's crazy. It's a crazy situation. New place, new people. It's noisy. It's busy. The person with dementia is sick, and it makes them more confused than usual. The caregiver, if they're not there because they have a full-time job, they might not be there to report what's happening or reassure that loved one that they're in the right place, what has happened. And people with dementia may not be able to report to the people in the hospital when their caregiver is not there, what problems that they're having in that experience itself. So what can we do as to coach caregivers to try to prevent delirium? Observe and share with the staff what's happening, what's different about what the person is doing, saying, or experiencing now that's different from in their normal life, even in a high stress situation. We tell caregivers to kill the TV. There's a beautiful TV in almost every hospital room, especially if you have a private room. Kill the TV. It adds to confusion, distraction, noise, sounds, etc. So killing a TV is part of reducing confusing situations. Make sure that they're maintaining their food intake and hydration. But if all of that doesn't work, in extreme situations, medications, those antipsychotics or other forms of medication are used. So then now what? Now we've been through this hospitalization, we have survived it, we're getting towards the end, we're getting to discharge planning. Caregivers don't know that term. Even if they've had kids who've been in the hospital, it's just like, I'm getting out. they don't understand that it could be a planning process, that their loved one, if they're eligible, they have rights under Medicare. They may have rights under the CARE Act at the state level. So that's a mandate that hospitals must notify an identified caregiver of the discharge plan itself, the full written plan for their loved one in the hospital. It's an act in 42 states, District of Columbia, Puerto Rico, and the Virgin Islands that says that you're going to, at time of hospitalization, record the name of the family caregiver or other primary caregiver in the medical record, that they have to be informed, that caregiver has to be informed when the individual is going to be discharged. So if they're not in the hospital right there with them, they have to get a telephone call, and they have to provide the caregiver and the person with dementia with the education and instruction on any of the medical tasks that are going to be needed. Like I said, my grandmother was hospitalized for her gallbladder. I had to learn how to clean out her lines. You know, things that people within the hospital to do have to be clinically trained to do. I'm going home as a caregiver to do on my own. The CARE Act says I have to be trained while in the hospital before discharge, and it's a right in 42 states and a couple of territories. We ask caregivers to ask about delirium. Did it happen? If they didn't know, if it is noted in the chart, that's something that they are maybe carrying home with them, including medications. They don't know, caregivers don't know that you can ask for physical therapy, occupational therapy, home health, or nutrition and counseling meals as part of the discharge plan. And lastly, they need to know that they're going home with a new, appropriate, right now list of medications. Don't go back to your old meds at this point in time until things change. This is the new medication. And also that they leave the hospital with the medications. Many clients leave the hospital and they don't get those follow-up medications for 3, 4, 5 days later. Many medications, especially post-COVID, were not available at their typical pharmacy, and they're left without medication. So try to make sure that they're leaving the hospital with those medications. So we've helped them, we've taught them about who's in the hospital, how to get out of the hospital, but now after the hospital, we want to prevent readmission. This is all about preventing hospitalization. Preventing rehospitalization is a problem. We want to be on the lookout for these items, and caregivers should be immediately on the lookout for delirium. So if there's a sudden vast change, that's something that they need to report back to the hospital. If there's a new fall or incontinence, if they notice pressure ulcers once they get home, if they have a loved one who's now showing signs of untreated pain, if they're not eating, if they're not drinking, these are big problems that could land them back in the hospital, and any problems with sleeping. Because again, 40% of people with dementia are going back into the hospital. So after the hospital stay, social workers typically are part of the team that helps to implement the discharge plan. We've got their notebook, we've got their written plan, we're contacting them if that's part of the job that we have. After the hospital stay, recovery for the caregiver is just as important. We want them to continue on. There's my grandma again. This is this Mother's Day after a 3-day stay in the hospital. This is what she looked like on Mother's Day after me being there 24/7. This is what I looked like, what the cat dragged in. I needed to be connected to resources. I needed some geriatric care management to help me. I needed to have some other resources, and that's where the caregiver comes in. And one really great resource that I have been working with for the last 5 years is Nevada Senior Services out of Las Vegas, Nevada, which cares for Clark County, which is, while it's Las Vegas area, it's also an extremely diverse community with even frontier areas that they serve. So they have a social work-led care transition program that helps those caregivers who look like what the cat dragged in after a hospitalization at the end. Their particular work is to get medical stability from the moment that the person is still in the hospital. So this is a social work team, total social work led, that goes bedside to help people go from the hospital or an acute rehab stay and get home with all the right resources in place before their loved one leaves the hospital. That's a typical care transition program, but this one provides something that's a little bit more dementia or chronic care based. So their key ideas that they're trying to put forward, they're trying to reduce caregiver burden, get people long-term access to support care to reduce the risk of rehospitalization. They try to improve health outcomes as well. So they have served 3,000 cases to date. And since we know 40% of people get rehospitalized, this particular program has had an incredibly impressive one person, not 1%, one person in 3,000 cases has gone back to the hospital using their philosophy. So they have a 3 kind of tiered approach. It's a care transition. They provide respite coaching, which is to reduce caregiver burden. What they do with that respite coaching, they do find respite. They find people to come in the home. They allow the caregiver to go out for rest and relief and self-care, but they also look for things like adult day. So Nevada Senior Services is also an adult day provider. They might encourage, as part of the discharge plan, direct discharge to their home care. So this is their team. They're real people. They're all social workers. Hello to them. And what are they reporting? They've got 33% of their caseload per month are people with dementia, and of those, 13% are living at home. They're dealing with problems that are represented. So why can't the discharge planning process happen? Social workers are in there because people don't have the ability to self-manage. They have caregivers with extremely high levels of caregiver stress and can't bring the person home. And because of the dementia, the person might not have low engagement. And because of language and other challenges, they have low health literacy. So that's just the discharge planning, but what about to discharge? These are the most typical problems that they face, that this social work team faces. They are obstacles to discharge themselves. So the discharge requires families to feel in a patient-centered plan that what they're being told to do upon discharge is both acceptable and actionable. And these are the problems that they're facing when they get home. They don't have the support in home. 13% they have of their caseload are living alone. They are confused with their discharge plan. They don't have a plan for follow-up or transportation to their appointments. But with all of that, this particular program with the social work base from bedside to bedside at home is providing direct referrals for support. Now, these referrals for support, this is not referring them back to programs and services that they were working with before hospitalization. These are new services that the social work team at Hospital to Home is providing to people at bedside so that they're ready when they return home. Respite care, home delivered meals, new housing, change in housing, direct caregiver support, and transportation are the top 5 things that they're doing. So social workers are extremely important with this particular program. As I said, 1 case in 3,000 because social workers were by their side, coaching the caregivers with all of the tips that I mentioned ahead, thinking about how to reduce the challenges that you may face in the home, and doing it from a holistic perspective that we as social workers carry with us.